Well, I bet you can't guess what we're going to be talking about in this one. Yeah, asthma. Okay, let's get to it. Asthma. Right on. Uh, First of all, I wonder if anybody could tell me what medication this actually is right here. Yeah, most of you would probably say albuterol, and you're probably right. Yeah, you are. You're probably right. That's most likely albuterol. Your generic albuterols usually come in this kind of blue container that you see here. But I've also seen generic albuterols in orange. I've seen generic albuterol in a little red, smaller inhaler, all kinds of stuff. I've also seen them in pure white, where the entire casing here, this whole casing is white, and so is this guy as well. Whoops, got rid of that. Didn't mean to do that, but that's okay. Asthma. All right, so let's talk about asthma. So you will hear some people say asthma is a form of COPD. That is hogwash. It is absolutely not a form of COPD. Not true, not at all. Asthma does have some obstructive properties to it. There is some obstruction. We'll talk about that in a couple minutes here. But asthma is also restrictive. But here's the thing about asthma. Even though people have asthma, and you could technically, I guess, say it's chronic. If you really wanted to say that, you could. But the truth is, it's episodic. Episodic. Asthma is episodic. Asthma goes from episode to episode. So when I wake up in the morning, even though I do have asthma and I carry around the thing that I affectionately call a nerd pipe, so even though I have that and I carry that around, I'm not having an asthma attack, as you can tell right now, and I'm not having an asthma attack, pretty much just at any point in time. My asthma is episodic, so I will have asthma attacks from time to time. Okay? So there are some reasons for asthma that we have to discuss. So first is what we call intrinsic asthma, I-N-T. Yeah, sometimes I have to spell things out. Don't laugh. Intrinsic asthma. Intrinsic means that something inside the body is acting in the force here. So basically what this is, what we also call it, is exercise-induced. Induced asthma. Exercise-induced asthma, which means when I exercise, I get, or I guess the way I spell it, exercise. Anyway, so when I exercise, I get asthma. That's just the way it happens. So exercise-induced asthma. Well, we're going to take away that exercise-induced. We're not going to keep that there. Oops. There we go. We're going to get rid of exercise-induced because we're only going to talk about intrinsic versus extrinsic. We're not going to call them by these colloquial terms like, exercise-induced asthma and stuff like that. We're going to use only the terms intrinsic and extrinsic. Extrinsic and extrinsic. So what does that mean? Okay, so intrinsic, generally it's when your patient, they do some sort of exercise or they push themselves in some way, shape, or form. Extrinsic asthma is different. Extrinsic asthma, what it is something outside of the body causes that asthma reaction. Now, I would venture to say, and I haven't exactly looked this up, but I would venture to say the vast majority of asthmatics are extrinsic asthmatics. Extrinsic asthma is probably much more common than intrinsic asthma. I don't know by what percentage or anything like that, but extrinsic asthma is more common. And the reason is that there's all of these things that are floating around out in the world, and here's Bill, right? Bill, there's Bill. You know me as far as my drawing goes. There's Bill. He's happy. He has no hair, but whatever. So there's Bill. That doesn't look right. Okay, how did that happen? Let's redraw that. There we go. All right, there's Bill. He's walking around all happy like. He's even got little feet. Look at that, little hands too. Okay, and here's this little these little bits of pollen that are just floating around in the air. That's a big piece of pollen right there, isn't it? Look at the size of this thing. If it got me, I'd be in trouble. Anyway, so here's this pollen. It's floating around in the air, and Bill breathes it in. Bill breathes it in, and Bill's lungs freak out. Now I know I'm going to draw this, and it's going to look like testicles, but I'm going to try to draw them. It still looks like testicles. Doesn't matter which way I draw it. Still looks like testicles. Anyway, Bill's lungs, they freak out. Oh my God. And my bronchial tubes too. Ah! They're just losing their mind. Okay? And so what happens with my asthma? Ooh, in red now. What happens with my asthma, with extrinsic asthma, is that my body is reacting, is essentially overreacting to that stimulus. Okay, and so what the first thing my body does is it takes these nice big bronchioles and it makes them into smaller bronchioles. Now maybe that's going a little bit far. Maybe they don't get that small. But they do get smaller bronchioles. All right, so my big bronchioles go into smaller bronchioles, right? And one of the ways they do that is by bronchospasm. So I get bronchospasm, and when I bronchospasm, it makes it harder to breathe. If you want to test this theory out, if you want to see what it feels like, grab yourself a McDonald's straw and walk up and down the stairs. When you do that, you'll kind of see what bronchospasm feels like. Well, so you get that bronchospasm, right? Well, so what's the treatment for that? The easy treatment for bronchospasm is to give a bronchodilator. Okay, a beta 2. A beta 2 like albuterol. Whoop, went off the page there. Anyway, albuterol. Albuterol is a really good beta 2 bronchodilator, and that'll help me out. That'll make me feel a little bit better. But we'd also have to talk about the fact that there is an inflammatory response to this extrinsic asthma, right? If I just get bronchospasm because I'm exercising, then a bronchodilator will probably just take care of that problem. That would be wonderful. That's great, okay? But when I have an asthma attack, I also get inflammation that builds up inside those bronchioles. So it makes bronchioles that essentially are small as is. Now it puts all of this inflammatory mucousy stuff in there, and it makes it even harder to breathe. Okay, so the next thing that I want to do for a patient that's having an intrinsic asthma problem is I want to stop the response, and so one of the ways to do that is to give Atrovent. Atrovent's an anticholinergic, and so that will help to dry up some of those secretions and to keep me from even making some of those secretions. Well, then there's some other ideas that I can also use, right? One of the other things that I can do is I can give something to that patient that will not just stop that inflammatory response, but will continue to decrease that inflammation. And one of the ways to decrease that inflammation is to give them a medication called Solumeterol. Solumeterol is a medication that is designed to decrease the inflammation. Okay? So we're going to decrease the inflammation there. We're going to bronchodilate first, right? We like bronchodilation. We're going to do that first, bronchodilate. And then the next thing we're going to do is we're going to come on over here and we're going to try to stop the process itself, right? We're going to act on the, you know what? I'll let you think about this one. Is it parasympathetic or sympathetic nervous system that Atrovent is going to work on? Mainly on parasympathetic nervous system. So that's what we're going to do, right? We're going to use that Atrovent and try to stop that response. And then Solumeterol to decrease the inflammation, right? So there are some other choices too. What if your patient is not reacting to these? You could say they're in some sort of refractory or even a status epilepticus, right? Or excuse me, not epilepticus, status asthmaticus. If they're in status epilepticus, this is not the treatment for them. There are other treatments for that. We'll talk about that in medical. I know that you hate that, but hey, we'll talk about it in medical. Status epilepticus has nothing to do with respiratory right now. Anyway, you get the idea. Bill, there goes the ice cream cone, and I just followed it. Anyway, so what I'm going to do is I'm going to decrease the inflammation with my Solumeterol. Well, there's some other choices if it's refractory and I'm not getting any really good response out of it. Well, I can use, believe it or not, some of you will be shocked by this, but you shouldn't be, epi. Epi. 1 to 1,000 is a good helps if I draw that correctly. Epi 1 to 1,000 is a good choice here. 1 to 1,000. There you go, Bill. Now you got it. Okay, so in my Epi 1 to 1,000, that's going to be a good choice here if I have a patient who really is not responding well. Now, if they're truly in status asthmaticus, so that means that they're just having this constant reaction, so the airway is reacting and then maybe releasing some and then reacting more and releasing some, or we're not getting any response whatsoever. Epinephrine is a potential choice, but mag sulfate. I'm a big believer in mag sulfate if I have a patient who truly is having a status asthmaticus issue. So we're not getting a good response out of this patient whatsoever. Mag sulfate is an excellent, excellent choice. Mag sulfate has very, very few side effects. Hypotension being one of the biggest concerns, has very few side effects, and it really is what I consider to be kind of a wonder drug when it comes to asthma treatment. And even a bunch of other treatments as well. We'll see that mag sulfate, we'll be using it more and more for other things in the future. So mag sulfate, there's a possibility as well. So we've got our Atrovent, our albuterol, our Solumedrol, our epinephrine, our mag sulfate. We could even be talking about terbutaline, and I usually write it as brethine. Yeah, didn't spell that right at all. Didn't spell that right at all. Terbutaline. Terbutaline. Let's just call it that. So I like terbutaline as well. Terbutaline is a nice strong beta 2. So that's also a good possibility. So, if we get into those really serious situations, we may be talking about those. I will draw this out a little bit better in just a second here, and I'll clean it up a little bit. I sort of wrote it, all over the board here, so we'll go over to here and we'll do some more asthma. All right, so asthma, let's review that. We said intrinsic, extrinsic, okay? So now let's talk about some of the signs and symptoms of asthma, okay? And we said asthma is episodic, so that means your patients are not going to be acting like an asthmatic on a regular basis. It's just not going to be happening. They may have some asthma issues and properties. They walk upstairs or whatever. They start to get tired. They start to have trouble breathing. Absolutely, very good possibility. So blood pressure in these patients is usually normal. Now, if they're having an episode, if they're having an asthma episode, there is the possibility of seeing an increased BP. But you could think about that in terms of reasoning. Why do you think their blood pressure would be increased when they're having trouble breathing? Yeah, most likely they're anxious because they're having some, they're having trouble breathing. So they're having some anxiety, and that would increase their blood pressure. Okay, we said earlier on in the CHF episode that heart rate in most of our patients that are having respiratory issues is going to be elevated. When the heart rate starts to drop, that is very bad. I don't like that. Okay. I don't like that. That's very, very bad when I start to see blood pressure drop like that. That tells me that my patient is decompensating, and that's a really, really, really bad thing. We're probably already late into a massive asthma attack here, and the patient needs a whole heck of a lot of treatment, which may, at some point, include intubation. But that's going to be for you to decide as a paramedic. You're going to make the decision on whether or not you really feel this patient is going to need to be intubated. So heart rate, we got our blood pressure, lung sounds. What are we hearing for lung sounds usually out of our asthmatics? Well, you know that. Wheezes. Most of the time we're hearing wheezes out of those patients. There is the possibility of having some wet sounds. Some wet sounds, But mostly in our intrinsic asthma patients, we might hear some wet sound, or excuse me, extrinsic asthma patients, we might hear some wet sounds just because we have some inflammation. So there might be a little bubbling or a little popping or something crackling, something like that. But in general, what we're going to hear out of these patients, oh, it's going to be wheezes, okay? In general, we're going to be hearing wheezes out of these patients. So lung sounds, there's our blood pressure. What do you think skin, whoops, put that in red, didn't mean to do that. It's okay, we can do that. Skin, temp and condition is going to be, what do you think the skin and temp and condition out of these patients is going to be? That's probably going to be mostly normal. There is that possibility, I should put this in here, cyanotic. Cyanotic. If they're really having a tough time breathing, there's a very good possibility that they're going to be a little cyanotic. That's expected. And so therefore, take care of the respiratory problem and you'll probably take care of that bit of cyanosis that they have. Sputum with these patients, we really don't have a lot of sputum. It's not like our CHF patients where we might see some frothy, pink or red tinged sputum or something like that. Yeah, of course, that's always possible with our CHF patients, but generally we don't see that with our asthma patients. If you're seeing that and the patient is saying that they have some history of asthma, start asking about other things too, because my concern would be that there might be some compromise, some immunocompromise, and maybe some tuberculosis or something like that. But either way, sputum, generally not going to see a lot of sputum out of these patients. If we see anything, it may be clear. We might have a little bit of clear sputum coming out of these patients, and that's really about it. It might be a little mucousy or something like that, but generally that's really it. Not a lot of sputum coming out of these patients. So let's talk about, one more time, asthma and treatment-wise, right? So when we're talking treatment, so generally the first thing that I go to, and what we normally would expect out of our end-tidal CO2 is maybe some shark finning like that, right? And that's indicative of what again? Bronchospasm. So I would expect to see possibly some bronchospasm out of these patients. And so give a bronchodilator. There's your albuterol. Now, in our extrinsic patients, which again, very majority of them are, Atrovent usually works really nice too. Atrovent can work really, 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 really good for these patients as well. And then the other options would be to go to something like Solumedrol. Now, I've heard some people say, and I really hate this, about Solumedrol, they say, well, I'm not going to see any difference in the patient in my transport to the hospital. Well, yeah, that's great. Thanks. Don't be a jerk. I'm not going to see any change, so why give the medication? Because the patient will see the change. So give the Solumedrol. The Solumedrol is a good choice. And the thing I'm going to start doing on these further lectures here is I'm going to start adding in the dosages for these, right? So my pencil stopped working for a second there, 0.5 milligrams there. We got our 2.5 milligrams. So what's our dosage for Solumedrol? 125 milligrams. All right, 125 milligrams. Let me get rid of some of this junk that's over here. So 125 milligrams. That's going to be our dosage for Solumedrol. So in really, really bad asthma situations, which we may get into, in our really, really bad situations, we may be talking about epi, 1 to 1,000. And I'm not going to give you the dose for the epi because I'm probably going to put that in a quiz just to make sure you're watching the video, right? So epi, we could be talking about mag sulfate, GSO4 is magnesium sulfate. So we could be talking about mag sulfate. Again, not going to give you the dose. You're probably going to have to do that in a quiz, or maybe, I don't know, you could see that somewhere else in the future. I wonder where. I don't know. Stop talking to yourself, Bill. So mag sulfate, there's your possibility as well. And then we could even be talking about tributylene. Tributylene could be another choice for this patient. So really, as the medic, that's where you're going to make your decisions. Generally, what I do is if I see that my patient is doing really well on my albuterol and my Atrovent, I'll give them the Solu-Medrol. So they're going to get this, they're going to get this, and then they're going to get this. But, if they did well on albuterol, Atrovent, and Solu-Medrol, then there's really not a point in giving them the epi to try to get any extra bronchoconstriction, or excuse me, bronchospasm. And Jesus, bronchodilation. Holy, I had a problem there. Oof. I think it was status epilepticus. There you go. Anyway, so if I start to notice that this shark fin waveform starts to even out, and that waveform is starting to go away with my albuterol, my Atrovent, then I usually just stick with my albuterol and my Atrovent. If I notice that the patient is not getting better or even potentially getting worse or not really changing all that much, then I will make my decision between an epinephrine and a tributylene. And if truly they're in status asthmaticus, then boom, mag sulfate. So that's what I've got for asthma. I'm sure there's more, and of course, there's more that we'll want to talk about, and we'll talk about it when we get together. If you wind up having any questions the next time that I'm actually physically in the classroom, we'll talk. So yeah, hope you enjoyed it. That's it.